Good morning, everyone. Thank you so much for the pleasure to be here today. Let me just get my timer started. So I like to talk, so I want to make sure I stay on time. We're going to go through reducing maternal morbidity and mortality through shared leadership with patients and community. I do want to acknowledge that this work was funded by the NIH, but anything that I express here today is not necessarily the official views of the NIH. We'll go through the project summary, then we'll talk about community and patient engagement broadly. Then we'll go through how we work together to improve the key delays that led to maternal deaths from sepsis, and those are delays in recognition, treatment, and escalation of care. So let's get started. This project was grouped into two phases. The first part was the planning phase. And so this was our opportunity to identify the barriers to care for patients, and then also identify the barriers to implementation from the provider side. And the way that we did that was we did qualitative work where we interviewed patients who experienced maternal sepsis and even interviewed family members if a partner had died from maternal sepsis, and looking at quality improvement opportunities there. Then we also interviewed providers to determine what were the barriers to implementation. So why weren't they implementing the sepsis bundle that we had created in 2020 with CMQCC, and also the bundle that we had created with AIM. And then we also took that time to refine our screening and diagnostic criteria for sepsis and pregnancy. But most importantly, this phase was to create strategies to address these barriers. With any implementation, if we don't address the existing barriers that are already there, you're going to have implementation failures. So we need to work to reduce those barriers before we even get started. So that was the first phase. The second phase was our implementation phase. We worked to implement the sepsis bundle throughout all birthing hospitals in the state of Michigan, and in California they did a small subset with plans for the rest of the state. And we had mentorship teams meet with hospitals every single month to go through what challenges that they were facing, help them troubleshoot, give them resources, give them some education as well. And we had followed the plan that CMQCC had done for many, many years, which was have a nurse and a doctor meet with hospitals monthly to talk about these things. Well, we thought it was really important that we provide that community and patient voice as well. And so for the first time, we included a community leader as well as one of the coaches. And then we also included a consultant with lived experience, so someone who is a maternal sepsis survivor, to give them that perspective as well. So that's the overview. How did we start? So before we did anything, we thought about how we could make the most impact with sepsis. And we thought about that if someone carries to full term, they're pregnant for 280 days, they're in the hospital for 3 or 4 days, and then postpartum for a year. And if we only focused on that hospital care, we would miss a really important opportunity to affect maternal sepsis, because people don't live their lives in a hospital. So we wanted to work throughout that entire time period, and the most important way to do that is to engage your patients and your communities in doing that. So we wanted to follow all of the important principles for patient and community engagement, and this is an approach that involves partnership and power sharing and decision making that is many times in combination with, but sometimes there's some decisions that they're going to make that are really important for their communities and patients. And it's really doing research with people that the research will actually impact. And so the first thing that we did before we did any research activities was recruit the Maternal Sepsis Community Leadership Board. And Kendra Smith is the liaison for that. We tried not to use leaders when we're working together because we didn't want to create power differentials, but Kendra Smith has a PhD in community engagement, and she worked with us, and we worked together with her to make sure that we were following all of these principles for appropriate community and patient engagement. And so we recruited a number of members, mostly members in Michigan and in California, because that's where the implementation was going to occur. But also nationally, we recruited people that had suffered from maternal sepsis, because it is a pretty rare condition. And the first thing what we did was we created a charter together. We sat down and got to know each other really well. We did a lot of status leveling procedures, and that no one calls me Dr. Bauer. It's Melissa. They have my cell phone. They have my email. We talk. We know a lot about each other. And we share all of our successes and our failures together. And we talk a lot about everything as far as maternal sepsis, but also, I received an email this week. Someone had just delivered a baby and they wanted to share their pictures, and we shared it with everybody, and there's a lot of respond to all, and it's all part of it. And so we created a charter that included standard operating procedures, decision-making policies, as well as a appeal process if there was a disagreement in some of the decisions that were made. And the purpose was to engage in research activities designed to understand and reduce maternal morbidity and mortality from maternal sepsis while leveraging community experiences and voices. Our members were maternal sepsis survivors, public health experts, health equity advocates, and community members from communities that have more barriers to care than in the suburbs, so in rural communities, urban communities, and tribal communities. We also had a clinical advisory board because we didn't want it to just be Elliot and I making all the medical decisions. We wanted to have nurses, midwives, and physicians all involved in this plan as well. So then now we had everyone together. We needed to work to reduce these 3 key deadly delays that we identified over a decade ago that was reaffirmed in California data that was reproduced to find that the 3 delays that lead to maternal sepsis deaths are delays in recognition, treatment, and escalation of care. And so the rest of this talk is going to focus on those delays and what we did to reduce them. And just if you're looking at your clock, 90+% of it is recognition, because if you don't have recognition, you don't have the other 2. I promise I'll finish on time, but let's go ahead and get started. So starting with recognition, we know that maternal sepsis is different, and we need different tools to help identify it, in that a lot of the physiological changes of pregnancy are very similar to signs of developing sepsis. So what happens with that is that patients are identified much later in the disease process, and time matters. So unfortunately, they're getting identified later, getting later treatment, and that leads to worse outcomes. So as far as screening systems, I don't have time to go through all of the incredible work that our team did, but we did publish several of the papers about it. But one of the biggest things that we try to do when we're doing statewide implementations is we try to say, try not to tell people exactly what to do. We give them the important principles and allow them to make decisions. And so we recommend that they use one of these screening systems. There's a ton of them out there, but we recommend that they use one. There's more and more data that show that it does reduce severe maternal morbidity. So we recommend that they use one, but also that they review their cases. And so if they're constantly missing cases because of the tool that they're choosing to use, then they need to be modifying that tool. We also recommend that they need different screening during pregnancy and immediately postpartum. This is also in line with CMS guidelines for SEP 1 that our team was able to meet with them and get them to change this. But that during pregnancy, so starting at about 20 weeks all the way through 3 days postpartum, we recommend a pregnancy-adjusted screening tool. And the reason for that is that their heart rate is much higher. It's about 25% during that time. And so it's really important to help identify those patients during that time. They're going to have an elevated heart rate without getting all of that alarm fatigue. And then prior to that, so during that less than 20 weeks phase and then after delivery, the heart rate actually jumps back down to normal pretty quickly within 24 to 72 hours. So we want to make sure that we're not still using that pregnancy adjusted criteria, because if you do from the time they're pregnant until 6 weeks postpartum, you're going to miss patients. And we showed that in our work. So it's really important to not use that criteria after that, because they may not have that elevated heart rate after they've gone home from the hospital, and they also may not have that elevated heart rate early in pregnancy. So you want to make sure that you're using a non-pregnancy adjusted tool during that time. This actually, I know it sounds confusing, but it's actually pretty convenient, because many times patients are seen in the ER at less than 20 weeks. And once they are discharged postpartum, they might go to the ER as well, and they'll be more comfortable using their non-pregnancy adjusted screening tool. So a couple of in-hospital recognition pearls that we taught not only to our community members for community dissemination, but also to our hospitals when we're doing our work, was that most patients don't have any risk factors. We found that quite a bit ago, that most patients just don't have risk factors. And so if you only focus on those at risk, you're going to miss the majority of patients. But also, no fever does not equal no sepsis. We've shown this multiple times in several different studies, including patients that have died. 25% of them never developed a fever or hypothermia for that matter. So it could be from taking fever-reducing medications such as Tylenol or Motrin, but it also could be from immune modulation that also occurs. So we really work to educate within our communities too that you don't need a fever to actually have a serious infection and that you may not even have any risk factors. We also, looking at some of the papers that we had done before, we noted that most cases occur outside of the hospital. Remember, outside of the hospital is a really important time. So how can we help patients identify when to seek care? When we looked at the maternal deaths in the state of Michigan, many of them died at home, and we didn't know what happened. We didn't know if they reached out to seek care and they were dismissed, or if they just didn't know the warning signs to seek care. So those are both really important. So how can we help patients know when to seek care, and how can we help them feel heard when they do seek care? When we did our qualitative work of interviewing patients, we had common themes. So with theme saturation, we identified a number of themes that I'll go through and what we did to address them. But patients overall didn't remember education about warning signs. So we're either not doing it well, or we're not giving them the information in a way that's accessible. And so we have to address both. One of our exemplary quotes was, I think if when they discharged me, if they had said, be on the lookout for these warning signs, if you have any of them, call and check in. If they had taken 5 minutes to do that, I think it would have made a huge difference. And so what we found with our work, we interviewed every single patient that had maternal sepsis or had a family member that died of maternal sepsis, and all of them actually had one or more of these warning signs. These are from ACOG. These are copyrighted by them, and they are used in the AIM Cornerstone resource. And these are not just for sepsis. These are all severe maternal morbidity warning signs throughout pregnancy and postpartum. They're free to use. They're translated into over, I think, 90 languages now, and you can even request more. And this is a way to provide standardized patient education. We know standardization saves lives. There are actually quite a bit of data out there to show that patients do not receive the same discharge education from different nurses. And we want to make sure that bias is not seeping in there and that patients get all standardized education. And patients really do enjoy this. It's a really great resource for them. And it has infographics. So if you have challenges with literacy, that's also really important. But when we asked people, we asked too, how do you want to receive information? So it's not good enough for us to just give people information. We have to ask, how do you want to receive the information? And we talked to our community group as well as patients when we were interviewing them. And they overwhelmingly said they wanted it on their phone. And so the packets that we're very attached to, that we like to give out, many times don't make it out of the car, or they get coffee spilled on them, and people just really aren't looking at them. So we have to also evolve with the changing, technology and give that to them on their phones as well. So we created this with the community leadership board. This is a badge buddy that goes on behind the nurse's badge. The patients will scan this at discharge and follow the instructions to have it as a bookmark on their phone. And so we sent this to every single nurse in the state of Michigan and more for when there's turnover, so that they could have this and other resources that I'm going to mention on their phone. We did have some implementation barriers with getting this going. I'm not gonna sugarcoat it. And so we decided we needed to pivot, which is really important in implementation science. And so we moved to cutting out the hospital part. We're talking about it's really important outside of the hospital. So April Chavez is one of our maternal sepsis survivors who works with us. She's also a graphic designer, lucky me. And she created this, and this is a business card. It's on the size of a business card. And we now give this out. And so people can have this. They have all the information they need, because community-based organizations as well as patients really responded well to getting this on their phone. They weren't getting it because there were some barriers in doing that. And so we wanted to just bypass that and have this so that people could just give it out. It's a one-stop piece of information, and it addressed some of the implementation barriers that we had. And so now we're distributing this throughout our community right now. And so I want to talk a little bit about community dissemination. Remember, it's so important to do this outside of your hospital. We had the support of so many people within the state to help get this information out, and they really responded well to it. We worked with our public health departments. We also worked with every single WIC site in the state of Michigan. We also worked with community-based organizations and houses of worship. People get a lot of their health information from their churches. And then also we worked with the doulas that were supported by Medicaid, as well as the home visiting nursing program. It's really important for us to understand that when patients have something wrong with them, they do not call their doctor and they do not call 911. They call their friends and their family. They call people that they trust. And it's based on what they think happens next. And so when a man has a heart attack, they actually call their spouse first. They call their partner. And based on what they say, they call 911, they go to the ER. And women actually do the same thing, but there's actually less concern when they start reaching out, because for some reason people still don't realize that women is one of the leading causes of death. They don't reach out. And when we were talking to our patients, we heard that people just didn't know that these things were concerning, that they were experiencing. And so if we don't educate everyone surrounding the patient, that they're not going to get the care they need. So we need this to be widespread, just like all the public health campaign for strokes and heart attack. Everyone knows when to seek care. We have to do that for pregnancy too. So everyone needs to know what these warning signs are. As far as advocacy, remember we talked about we don't know if people are feeling heard. We found that that was a major theme, and that patients really felt like they had to advocate for themselves to get the care that they needed. And one person said, I wish someone would have explained the signs and how to advocate for themselves. If you call and they tell you don't come, still go. And so we wanted to create a document to help people with that, not to say that it's on the onus is on the patient to have to advocate for themselves to get the care that they need. But while we're working on listening better, we need to provide people with that resource. So we created advocacy language and advocacy actions. We had a Zoom Jamboard session, and we had all of our community members as well as patients and our physician members work together to give words to say and what to do if you're not feeling heard. And we made sure that this was anonymous so that when I was putting this together, I didn't give more credence to something that a physician said compared to a community member. And we created this advocacy language and actions. That's a QR code that's live. You can take a look at it, go under patient resources, and you'll see all the resources we gave them. We use the same QR code because if you have multiple QR codes, someone's going to get the wrong one. So that's why we did it. I'm not going to go through all of this, but it really just gives people the words to say if they're not feeling heard, because they really didn't know what to say when they were in that circumstance, and also what to do as well. So bring a doula with you, bring a friend with you to help you advocate. A lot of really good information there. And so then this was a big one. Patient concerns were dismissed as normal or normal for pregnancy. CMQCC talks about this a lot. And one of the quotes that we had here, this was from a husband of his wife died during her hospitalization. He said, she's dismissed there and throughout the whole stay. Whenever we brought these things up, it was, you just had a baby. Everything's okay. Don't worry, you just had a baby. And that was the recurring theme throughout our stay. But they never asked further when she brought up those complaints. And so it's a really common complaint postpartum for someone to say, I feel really tired. But no one asked, when we interview these patients, what does that mean to you? What are you not able to do? And if they had asked, this is what they would have heard. I had no strength. I couldn't even go to the kitchen to get a glass of water. I was so weak I couldn't stand up. And I was short of breath after brushing my teeth and had to lie down on the bed. That's very different. These patients can't do activities of daily living because of their fatigue. And so we need to make sure that people are asking really important questions when people call. So we did the same process to create a warning signs follow-up. follow-up guide. And this is just a really great way to ask good questions, to get a good history and also action items. So what, if the patient doesn't need to be seen now, what should you tell them about when to be seen? A lot of our patients didn't realize, they thought, well, I already talked to my doctor, everything's fine. They didn't know that if it persisted, if it got worse, if this changed, that they needed to seek care. So we provided that resource. Also, some red flags of these patients need to be seen definitely in person based on some literature as well as what we found with our qualitative work. Severe pain was actually a pretty common thing that we experienced with sepsis. I was pretty surprised by that. That was one of the first signs before they started having other symptoms as well. So now moving on to treatment. And treatment, antibiotics are really important. We know there's higher mortality if they don't get the antibiotics they need. We also listen to our hospital communities about how to get antibiotics quickly to people. So working to get it in the Pyxis was really important, having an order set, knowing which antibiotics to give, and then also having IV access. That's somewhere we can be really helpful, starting more IVs so they can start more than one antibiotic at a time. Otherwise, it's 2 hours for this, 2 hours for that one. It's 6-8 hours. They haven't received all their antibiotics. So we can step in and make sure to help with that. And then working with your pharmacies to get antibiotics quickly. And then fluid administration, it's 30 per kilo over 3 hours. I got a lot of hate mail over this because people were really upset about giving too much fluid. So I had to make a chart that I widely distributed of what ideal body weight actually is. And it's really sad, but if you're 5 feet tall, it's 100 pounds. So I had to make this chart, and 6 feet tall, even if you're a supermodel, you only get 2 liters. So this actually really helped everybody stop refusing to give fluids when patients had sepsis. And lastly, escalation of care. We recommended the sepsis and obstetric score. This is retrospectively created, prospectively validated to identify patients that need ICU admission with a score of greater than 6 or more. And I can't remember that chart, but if you go on your phone, you can go to perinatology.com, and there is a drop-down menu. You can enter what your patient has, get your score, get them admitted to the ICU. We put it on the Badge Buddy. Remember, we talked about we have provider resources as well, so that way everyone can find it at any moment. And we have a number of resources available if you're interested in implementing. And just a little plug, tomorrow the update of the sepsis toolkit by CMQCC drops tomorrow at 3 p.m. Eastern Standard Time, noon Pacific time, so please register for that. And thank you to the community board, clinical board, and all of our mentors. And I look forward to your questions. And my last question for you is think about how can we work with our communities and patients to improve maternal morbidity and mortality. Thank you.